Nice for you.
Yeah.
What are you, JW Marriott Intercontinental?
Yeah,
Like, don't give me that.
Hello, America. We're live at VIVE26 Health Tech Talk Show. And I just want everybody to know that we have gotten enough money from our loyal supporters that we have been able to buy more than 2 mics.
We assume it's working.
We believe
I was
they
going
work.
to just yell over.
Yeah, well, that's what I know. That's what you're used to.
I know you think that's what we do.
And we also have like a real camera, so it's unclear what's going to happen.
If you guys are like wowed by the incredible quality of this, then just that's
keep sending us more money.
Yeah,
this is what happens when you have money.
Don't worry about this.
Oh, okay. So listen, we're at VIVE. It's great. Melissa has once again bullied her way into an amazing space here where we are not supposed to be, but seems all good. And our first guest,
if you need a fixer from Jersey,
you are our first guest of our Live at VIVE series.
If you need a fixer from Jersey, it's not Paul Wilder.
Mr. Paul Wilder.
He is a Jersey guy,
CEO of the CommonWell Health Alliance, who is, by the way, one of our most frequent guests and my mom's favorite.
That's why you keep getting the spots.
Yeah. So Paul.
Hi.
What's going on?
Well, first, apologies to my wife and the 18 inches of snow she's dealing with my puppy at home.
Oh.
So if she's watching, I am sorry. Yeah. Sorry. But hi. It's great to be here.
Yeah. So like, what have you been doing? You closed some deals? Did you make interoperability work?
He's been beating me on United Miles.
Yeah.
I am beating you on that.
He is. Yes. He is.
Yeah. Cross-country trips are expensive.
They really are.
SFO market for Newark is not cheap.
They really are.
United's milking that, I gotta say.
Yeah.
Well, no deals. We're actually, so I don't know if we're going to be in heavy deal mode this year. I think this is a maintenance mode year. There's a lot going on. It's time to look at what you have, make sure you know what it is, get rid of the garbage that shouldn't be there, amplify the good, and stop the noise. There's way too much noise right now about bad actors. And I'm telling you, it's not signal, it is noise.
Okay, listen. Last year is the year of the snake. Now it's the year of the fire horse. We're already done shedding all of our bad stuff. Why are you still in snake mode?
I'm helping others do snake mode because they're not doing it right.
Are you burning off?
No. So here's the thing.
Burning off, burning it.
This is not like a massive critique of everything.
Yeah, we're actually like very interested in this bad actor stuff. So like, you go.
Tell us why it's a farce or why it's not.
Yeah, why is it noise?
Why is it just noise?
If I showed you a top 10 list of the exchangers in care quality and CommonWell, they would all be very big provider practices.
Okay.
Right. It is not this vast amount of data disclosure going on. There are a couple things that are
not all integratorts, allegedly.
No, it is not. It is not. Even the idea of mass tort isn't that mass, right? It's an authorized person at a couple thousand. It's not a million pre-requests on a list of people that they got from a mail order. This is not the same thing.
But like, what percentage of bad guys, like what percentage of exchange is happening with bad guys?
I bet you it's point something percent.
Point something percent.
I'm working at measuring it, but I did a top 10 stacking, just a top 10. Just take a look. Who's first? The VA. Shocker.
Right.
Next was a couple things like Kaiser, Tenet, HCA. These are all things you've heard of that you would expect to be the high exchangers. Those exchangers are so high, when you take them off the table, the amount left is single-digit percentages, right? It only takes you you get rid of the top 100 and you've gotten rid of 90-some-odd% of the healthcare to exchange, and they're proper actors doing what they're supposed to do. Yeah. So I think half the problem we're having is we have that the trust issue is happening. We have a puzzle of 10,000 pieces with and no one knows where to start. It's time to profile. Right?
What does that mean?
Take the good actors and get them into a clean directory or some other, like all the epic sites, take them out. Like we started a directory thing in care quality of looking one by one.
Yeah.
And that's asinine. If there are bad actors in Athena, like they're already got. Like they found them and got rid of them.
Yeah. And
they were probably gotten rid of not because they were doing bad data exchange. They were probably milking fraud. It was probably Medicare fraud.
Yeah.
Like it was straight up. They were a provider according to CMS, and they gave them $20 million of DME money in Florida, and they disappeared. Like that's not what we're talking about. So you gotta take Athena, Oracle, eClinicalWorks, Epic. Just take all their things out of the directory and stop looking at them. Look at the rest.
It's like TSA pre-check.
No, it's like Israeli Airlines. You ever fly on El Al? If you're, they know you. Profiling. They know you before you get there.
Profiling.
Okay. All right.
So we know a lot of these
around
things.
your argument.
Okay. Listen, I think the Israelis are pretty legit, you know.
They're unabashed profilers. When you show up to the airport, you go, you already know what your answers are.
You better you better be more than 3 hours before your your flight.
I can't wait to write the recap of this time with Paul when we talk about how
we should be profiling people on the exchanges.
No, on the positive side, we got to get rid of.
Don't act dumb though. Like there's no reason to act like that. Like it's not. You know what I mean? Like you're saying like we know who's likely to be doing a fraud.
Well, no, I think actually
we do though.
But I'm taking the opposite approach though for the fund. Well, that's common. Yeah, that's
sure, but that's a heuristic where probably if you're LL, you're like Florida DME, that's a fraud.
Yeah,
I did use the example for a reason.
Yeah,
because anyone knows healthcare is like, oh yeah, that's where they do
that. That's where the fraud. That's where they do the fraud.
There's a strip mall.
Sorry to our friends in Florida, but
I mean, that's what we hear.
I mean,
allegedly.
There's a bunch of strip malls, but they're doing millions and millions of dollars of DME a week.
Yep. That's what I'm
for
talking
2 months and never seen again. Just saying, I don't know.
Yeah, then they move. They move after they train them. They move out. Okay,
but that's not the fraud we're talking. We're talking about people that are misrepresenting as treatment.
Do you know how much? Okay, of the point whatever percentage of fraud. I don't know if they can hear that. I think we got the real mic, so it doesn't matter.
Hopefully.
Of the like, how much money are we talking? Like, is this the great monetary scandal that everyone would have us believe on the internet?
I think that's totally bupkis.
Yeah. Well, there's not a huge amount of money connected to it, is what I would say.
Okay, so right? I'm going to ask a question.
Okay.
So
we love questions.
So someone goes.
You interview us.
Yeah.
Well, no. So because someone goes to a law firm.
Okay.
They just had a car accident.
All right.
They want to get their medical records to help the law firm assess if they can go forward with a case. Okay. They think they had a back injury. Okay, cool. What does the legal firm do next?
They go and try and collect all the medical records, see if they can make a case.
And why? What are they looking for?
They're looking for something that would indicate that it was caused by that, whatever.
Correct. Yeah. So if you have lupus for the last 20 years, you might have had back pain in your record for 20 years. And we have tremendous sympathy for you, but you're probably not going to get money out of the person that just hit you in the rear at the stoplight. Yeah. Like they're not the cause, not cause and effect.
Right.
So they're determining if it's worth proceeding on probably a contingency case. Okay, so that provider of legal services says, to make this assessment, we need your data. I need you to authorize that, and they sign something.
Yeah.
Okay. They get a provider in the middle. So this is called the provider in the middle attack. They get a provider that's contracted by the law firm, and they call this request secondary, like a second opinion. They say, this provider is going to look at your old records and provide a second opinion that we know is, in fact, a secondary use of a second opinion. It's not a real second opinion. It's determined if the lawsuit you go through, right? But they send it through treatment because an MD is attached to that request. Now, doctors working at payer plans, there's a lot of them. They're not doctors when they're there. They're doctors when they do their voluntary thing to maintain their license. Okay, so it went down the wrong channel. They went down treatment. But I have to ask, who was harmed?
Well, I mean, all good, but the second we start sort of like blurring the lines on treatment, as we know, people get upset and fussed. Is there like material patient harm in that situation? No. But if we start saying that that's okay, then like you just
not saying it's okay.
And like you just said, like every MD who works at a payer organization can say, well, I am an MD, so therefore blah. And we're saying it's not about your credential.
Yeah.
It's about the use case, which in that case is not treatment. I still think it's fine. Like they should honestly be able to do an individual access request because that patient consented and said, yeah, blah, blah, blah. You know, it's not,
I put you in the stand.
Yeah.
I put Kat in the stand. I say, Kat, did you hire, we go sue him and how? Yes, I hired me. Did you authorize them to go get your records? Yes, I did.
Do we cheat
Where's
him
the
and
harm?
how?
Well, I was not trying to.
Well,
not all lawyers are bad. I know a lot of lawyer friends.
Do you think we should just abolish secondary use?
No.
Abolish it as in not allow it?
Like we can't, like
that's
no
her.
more.
That's her perspective. Everyone.
Just take it away.
That's a Cat opinion.
No more secondary use. No
Cat opinion.
And we will see empires collapse. That's how I'm going to save Tefta.
That sounds
I only like the idea because it's dramatic and it's fun. Like I like the drama.
It's as dramatic as many of the other ideas we have.
To Lisa's point, though, what is the real problem is we can't open the other lane.
Right.
We've shut down the other lane. So of course they got to get creative.
I should be.
We have to open the other lane.
This is me. I swear it's me. Here's my authentication, retina, thumbprint, whatever. And like you got to release this, and you can't say, "Oh, we don't respond." Like, no, you have to.
I think like patients, that's
See, you're back to what I think, which is like just follow the legal pathways that should be
of course.
respected
And
enforced.
everybody will save money.
Okay, but here's the
I'll
thing.
tell you who's harmed if you really want to know. It's the medical release companies that get paid per transaction.
Oh, are any of them coming on our show? No.
Well,
Okay.
they're lovely people too. They serve a purpose and they do a very good job at it, but they're the ones that are harmed.
Well,
yeah.
Can't charge
So-
$75 if it doesn't exist.
Okay.
So but here's like my thing. Okay, so you're saying, hey, there's only a few people that are bad. And
Well, I
like,
think it's actually a lot of things doing a very small amount of
I
transactions.
don't know, like
He's just saying it's not a big burden on the system, so you're overreacting, you're overcorrecting for
do you know
a
who
very
I am?
small
Over-indexing.
Obviously.
Over-indexing, thank you.
Yeah, but like we shouldn't have bad guys.
Sure, but
Of
by the
course
way,
not.
So we're doing the profiling.
any system though.
Do you speed? You do the speed
No,
limit
my
all the
Tesla-
time?
My Tesla
You
drives
only
itself.
do way
My
more now. 'cause it
My
only does
car
speed
drives
limit.
itself, and
Yeah.
then I have a driver. He may or may not speed. It's unclear.
And so the
She's
driver
outsourcing-
itself,
she's
you hit the
outsourcing
little button,
the
it's like,
risk.
you can go 10 over. It's
She
okay.
said-
No, I don't do that. I just
Come
let
on,
it
you're in
drive
Atlanta.
itself.
No one
I
goes.
let it-
You
I
either
let
go,
it-
you either
I
go
let it-
90 above the speed limit or you go 0 in Atlanta. That's the only two
Okay.
speeds you have.
The point is,
What?
No, I
I
agree
differ.
with you.
I'm just saying I don't drive anymore. Like, I'm
The
like,
car driving with you in the driver's seat counts as driving.
ask
according
me
to
if in the
the law.
pre-check line if I sometimes have toothpaste over 3 ounces. Yes, sir, I do. So I am.
How much toothpaste are you carrying around
Well,
with you?
sometimes I don't have the little one. I have to get
Just
the
in
big
case,
one. Yeah.
note to everybody,
You know what I'm saying?
if you're like, oh my God, I forgot
Criminal.
toothpaste.
Cat
I
has
have-
a whole
I have
big old tube of toothpaste.
So much toothpaste. You guys don't even know. Okay.
I totally get your point, and I think I also will just remind that any system is going to have some amount of fraud, waste, and abuse. There's no way to eliminate
Can't
it.
get rid of
but
it.
I don't
You have to
think
still
we-
try and stop it.
there's
You have to
some-
try.
yes.
You have
You
to
have
try.
to try to stop it.
Yeah.
You can't just be like, whatever.
I don't think we should be like, no,
Yeah.
it's totally fine. That's
But there
No,
is
but
allowed.
shutting down, crapping on everything while that's going on and is causing disruption that is
Yeah.
unnecessary.
Yeah, but can't
There's
we?
one vendor out there that may have sued somebody,
Oh,
basically crapped on the care quality thing and TEFCA at the same time, sent a letter saying, here's how I want TEFCA fixed. They made it impossible to go backwards or forwards. What do you want us to do?
Yeah, but
Go
that was
sideways?
that's the point of regulatory capture, which Lisa and I have been talking about for like
they're
10
good at
years. Like, oh my
They're
God.
good at
They
it.
are so
Like
good at it.
everybody should have known this
Did
was going to happen. Do you know who
know?
knew? Cat and Lisa.
Yeah, we talked about it the whole
I
God
time.
know.
bless America.
We
And
may
they're
have
good
made,
partners.
we may have made some enemies with our position years ago on this.
Hello, it's true. I mean, no, we always gave
Cease
them
and
mad
desist.
props. We always said, God bless America, regulatory capture, best in the game.
You did a good job.
Well, I think the strategy from a market strategy perspective right now is amazing.
100%.
Don't get me wrong on that.
100%.
Yeah. Like,
Yeah.
Do I think it's right
respect.
for humanity? Not so much, but it's a
Not so
great
much.
market strategy.
Okay, he's almost out of time.
No,
so
okay.
let him
Oh.
make his final
So
point.
you are
How much time
voting
do I have?
pro
15?
LL. We're going to profile everybody. We're going to be hardcore transparency. We're going to publish the shit on the internet, right? Is that what you're saying? Because I'm in.
We're going to publish. Let's do it.
Let's do Paul Wilder, CommonWell Health Alliance, most secure and transparent national network in America.
Oh shit.
Trying.
What are your final
He's
words
trying.
for America and ViVE? ViVE.
Maybe
Melissa's
separately.
making kind of a
My final
Weird
advice for
face.
ViVE is maybe it's time to stop with February, March. Like
Oh, 100%.
Yeah.
last year, we all tried booking out of Nashville because they were going to have a little bit of snow. Everybody
Right.
left as early as possible this year. No one could make it because the entire Northeast.
Yeah.
I got out in the second to last plane, I think, out of Newark.
Yeah. Melissa got out.
She was on my
Well,
plane. She did
yeah,
standby
she
on my
did.
plane. I was like, hey, that's what
That's what I'm talking about.
but here's the thing, it is they're
little quiet this
they're gonna
year.
be at Nashville. And Nashville, as we recall, last time had the snow problem. They're not gonna escape.
It didn't even have
Like,
snow. We all left
We
on the
told
fear it was
worry
gonna
that
have
oh,
it.
it might snow. Yeah, not
I'm
great.
sick of
Oh,
snow.
what
I
are
have
you gonna-
14 inches in my house.
that's great. So,
I know, no, it's not.
so my mom does too. She says, hey.
Come on.
Okay, so your advice for ViVE is what the hell with the timing? What is your advice
Yeah.
for America?
Related to interrupt or just in
Anything you
general?
want.
It's time to grow up and like be a real country again.
Oh,
Can I
wise
say that?
words.
You can say whatever you
say
want.
whatever you
It's
want.
not
Okay, I
a talk show. Like,
We're acting like
this
children.
This is a fake news show,
Yeah.
and we support all
Oh,
of it.
great.
we support all opinions.
I treat it like a real news show. just
Well,
saying.
You know, I
That's
did
just
just have
you.
someone say we were the best thing
aw,
on LinkedIn Live. I'm
a
seeing the page
real-
pretty
Oh,
small.
we're fun.
that's a
Yeah.
real like. I'm sorry.
Oh.
Is it streaming anywhere?
Oh.
You gotta get them the TikTok.
Oh,
They get
boy.
the kids watching.
Oh.
Looks like it's streaming, but it's not.
Okay.
All right,
We'll see what's
great.
going
Well,
on.
we'll see.
Okay,
Fantastic.
Paul.
Okay, I'm done.
Yeah, you're the best.
Thank you.
Thanks, Paul.
Yep.
We're
We
gonna
love you.
message all the people.
God bless
I
America.
don't know who's next. Okay. Okay.
Thank you.
Okay. Thanks.
I didn't know you're so tight.
See
on
you
the
later.
15. Look at you.
Take your. Don't steal our.
Yeah, I
thing.
know. I won't do that.
It's an internet issue.
Internet issue.
Whatever. We're on YouTube.
But was it recorded locally?
Is it?
Oh my
being-
gosh, Paul, get out of here.
Oh my God, be
I just want to make
nice.
sure I have to do this
Be
again.
nice.
I only got enough energy
No, we're all good. We're
to
all
use
good.
it. The YouTuber to me wants out of here.
Oh my gosh.
I see.
So last year,
Wait, she's making weird faces. I don't know.
okay.
Okay.
I think it's Wi-Fi.
Hi.
Yeah.
Just flip this one on.
Welcome. Welcome back to the show.
Pop off. It's
Are we
just
still
a
going?
magnet.
Oh,
Just flip.
Oh, go somewhere else.
No, the top, like
Too loud.
Just like this.
Yeah, there we go.
Just the
Yeah.
fuzzy
Oh, we
thing
love
will
you.
pop off.
We're only
You're
like
good.
this with you because we love you so much.
Yeah.
That's
Dusty. Okay.
Yeah.
Okay. All right.
Oh my gosh.
So listen.
Back on the show. Hello. Are y'all good? Okay. Here we are. So last year, you guys might remember at ViVE. So we had a special video for my birthday, and tomorrow is Melissa's birthday this year. So we have repeat visitor Erin from CAQH. Introduce yourself to our real fans.
I just love celebrating birthdays. So we join you guys every year for birthday celebrations. I'm Erin Weber. I am the Chief Policy and Research Officer at CAQH.
Yeah.
Awesome.
So last year you came to tell us about what was in your annual index report.
Yes, that is
Yeah.
correct.
Is that what we're talking about this year?
It is. We released another one, and last year, if you would remember, I brought you a 73-page PDF document of the report. This year we have gone digital. So it's really exciting. We still have, executive summary. If you want something in print, you want to see it, but we have created Index Pro, which is like an online digital interactive platform where you can engage with the data, put in your own organization's data, measure your ROI, what benefits would you get, savings if you were to go more automated with your transactions. So really exciting. It's a bit of a glow up for the index.
Yeah, major glow up. So what are like interesting findings from last year? Like any new exciting things that you guys have?
Yeah, well, this year was interesting because the data is a year old, so it's 2024 data. So it was the Change Healthcare cyber attack year, and so we were able to see the impact. Obviously, we get the full year's data, see the impact of that incident, and the industry actually did a really good job. We didn't make a ton of progress this year. We increased our savings, but not as dramatically past years past. But we didn't lose much ground. There were manual payments in particular, like a little bit more manual this year. Really didn't improve in the way that they have been, but overall, steady state, which I think is good. Disruption.
Yeah.
What's most surprising about the way that the results shook out? I mean, I hear you have lots of energy probably spent on trying to respond to and recover. But anything stand out to you that was surprising?
I think the most surprising element we saw this year was that the prior auth automation increased another 5% from 35 to 40%. So we still haven't crossed the 50% threshold yet.
Wow, upsetting, but not right.
I mean, I do think folks are waiting for the 00757 requirements.
Is it not working?
Yep.
Why is it not working? I don't know. Oh, anyway, is it working now? All right. Well, whatever. Okay. Welcome to the talk show. Yeah. Well, prior auth. Do you think that's going to change next year with this whole the pledge?
I don't know about the pledges, but the 0057 requirements go in as of January 1st. So I do think maybe we'll see a little more automation. I know there's going to be some challenges with that as well. I saw your face. But obviously, the goal is to drive more automation. We are only tracking in the index right now the legacy X12 278 transaction. And so we've done some separate work on FHIR adoption. What are the challenges there?
Sure.
And what we're seeing is a lot of organizations are still preparing. Maybe 2/3 of health plans are building. 20% of providers even seemed somewhat aware that it was coming. So I think we have a lot of education to do with the industry around, from a provider perspective, talking to your vendors, making sure they're implementing the requirements. What are the benefits you're going to see? I think there's a lot of the provider community that could be changed.
Yeah, that's the problem when you have these dates. I mean, I remember when CMS 0057 was, announced and finalized, and they were like 2027, and it was so there was like, all right, I'll think about that and never in a few years maybe.
Yeah,
and
maybe.
so like it just doesn't drive like urgency of adoption. Obviously, the industry says like, no, this is too hard. Like it's going to take too much time. So the regulatory answer from the agency is like, well, just push it back.
Yeah.
Like give them a date that's like so far in the future that they're like, oh yeah, okay, whatever.
Yeah.
Maybe it'll get changed by then.
Yeah, and hopefully will. Yeah.
And that's a bummer because it's just it's just such an important topic.
Yeah.
Like critical.
And we need more time. And, the challenges that we're hearing on all the transactions are, legacy systems. It's hard to update them.
X12 never died.
Inconsistent inconsistent standards, and that's a challenge. And then resource management. I mean, there's so much going on in the industry right now. So and or go above and beyond is really hard for organizations.
Yeah. Speaking of X12, do you think it should go away?
I mean, we had that conversation at CMS like a decade ago.
Yeah. And then like
so.
every few years the CMS, someone at CMS or ASCP or something will be like, oh yeah, we're going to replace the X12 standard with FHIR. And I'm like, all right. I mean,
so some things in X12 work great for the industry, and some things like prior auth are probably right for some changes. But if you look at eligibility, for example, real-time eligibility, we've been doing it for 15, 20 years now. Right. 96% of transactions are done in real time. I don't know if we want to spend our time and resources on that as opposed to the millions of other things we could be fixing in our healthcare system.
Right, like it's not free. It's not free to make that change. There's a huge amount of time and energy and effort.
Cost, I think.
And
it's like 1/5 of the U.S. economy processed on X12 standard. So whenever someone says that, I'm like, okay. Let me know if you need help on your work groups so you don't get too established. I don't know.
You do not want to help with those work
No,
groups.
well, I would totally
Please
go. I would go. I'm not sure it would be useful.
You're like, all right, so what do we do with this work group?
Yeah, I'd be like, when's lunch?
We have a lot of industry work groups right now.
We do have a shortage of industry work groups.
We're not sure that that's the best thing for our buck is today.
But that's a good nuance point, right? Like working well for some things. Why would we spend the money, the huge amount of like cash, resources, energy, all those things? But then there are places where we really need to make a little bit more of a dramatic change. We can't continue in this pathway with prior authorization.
Yeah,
exactly. I mean, if you look at the index data, we're all between 75 and 99% adoption, all of those transactions, and then you got prior auth, and you got attachments. And where are we looking to FHIR for solutions? Those are the two areas. So,
those are the priority areas.
Prior auth and attachments. Yeah.
So, what are you doing at ViVE? What are you into?
We're talking about the index. We're talking about Index Pro. I mentioned earlier, it is now all automated. You can go in, play with the data, understand how it impacts the system. We created an AI system. So it has loaded all of the historical index data so you can ask historical questions. So that's the primary thing we're talking about, in addition to the millions of other things CAQH does around provider and member data. Busy time.
Yeah, awesome. Very cool.
Very cool.
Well, all right. Our boss is yelling at us, but hold on.
Yeah,
okay.
Yeah.
So tell us what are your health plan? Are they members or are they?
CAQH today. We have a position. We had health plan members, and now we have we are actually owned by several health plans.
All right.
Yeah.
So what are they? What do your owners?
Yes.
Your overlords.
Yes.
What do they think of everything going on with CMS, with the health tech ecosystem and all that? Like, is it like, or like, what are the vibes?
I think there's a lot of cautious optimism around, we're trying to do things in a different way, and maybe that'll work because what we've been doing historically hasn't worked either.
Yeah.
On the other hand, like it's a lot of time and effort. We talked about a lot of industry work groups and resources, and not a lot of reward for that type of work.
Yeah.
When you're running a business, so balancing the opportunities for the industry with business interests.
Yeah.
one of the things that we track in the index do is AI adoption along the administrative functions. And we did see a 50% jump on the health plan side from last year to this year in terms of last year was about 25% of plans said, yeah, we're using AI for administrative functions. This year it was 50%. Providers jumped from like 10% to 25%. So that's starting to play into the administrative workflow as well, and will be interesting in terms of prior auth and some of the challenges we've seen.
That's super interesting. We had a gentleman on our regular Friday show who works mostly with smaller plans, community plans, whatever, talking about like how how are they adopting AI. And he said, much like you're saying, like it's still relatively low compared to the provider community, but they're interested in trying to figure it out. Like, what are the barriers to adopting it? Like, at least what your plan overlords have told you. I'll come up with a word for them.
I mean, I think it's just the lack of ROI data. Again, it's you only have so much money to invest in these things. Where are you going to get the most bang for your buck? And how are you going to understand and learn the value of it? And so that's some of the work we're trying to do with the index as we expand over time. What are the cost savings? What are the time savings for staff? We'll continue to build that out as AI investment gets higher and higher.
Yeah.
Well, I mean, it may not be the case for commercial populations, but depending on the program, like if a payer or a plan is in a TPO style arrangement, have very, very limited margin to work with for any new investments. And these investments in AI are not cheap, no matter what anyone wants to tell you. You keep saying like, I'm sorry, did I miss the part where you said that like your AI SaaS is cheaper than your non-AI SaaS because AI is going to make things so more efficient. It's not cheaper.
Well, and
it's more expensive.
And like
that's
maybe in
also
a good
not
way, but it's not free to do that kind of workload transition.
Like it might be important to do. You might in fact save money over time, but you have to invest, redesign the workflow with the tools. That's not free. Figure it out and then start to find those savings. Nobody's going to do that for you. None of the vendors here, including my own, is going to do that for you. Like, we're going to try. We'll be like, let's show you the value, but we can't promise like what that looks like.
I don't know. That guy was super loud. But hopefully he can't hear us on our
super loud dude just walked by.
Super loud guy. I don't even know who he's talking about.
I think we are by the catering entrance, so it's always an adventure here at
the Health Tech Talk Show.
Always an adventure here at the.
Well, AI. Just we were talking about this earlier. The
catering.
AI. It's a great example of how you need human beings.
Okay, but with the AI. Because like I think speaking from experience here working with a lot of digital health vendors who are doing AI, they all is more money, right? And I think like what we need them to realize and maybe now are with the access reimbursement rates that we need to solve very low.
Less money.
AI is supposed to reduce overall cost in the system, and that's I think very hard for a lot of vendors and investors.
I think investors funded
companies
wait a second, a different thing in mind.
This was just going to be an add-on. It's like push. Who makes less money always, right? Like
who makes less money in this ecosystem?
With AI health plans, like who makes less money? Is it like reducing staff? Like,
I mean, how many times have you been in an AI session at a conference and it's like, we're going to optimize the staff.
We'll keep them all.
We're going to reallocate them to more important tasks.
I'd like to be reallocated to the snack table.
Very same salary.
The same salary, just to be totally clear.
It's not gonna.
But that's right. Like it's always a question of where it's going to go. Any final words for our loyal thousands, millions of fans and to ViVE?
I would just say check out the CAQH Index report this year. It's on our website. It is a really great resource. A lot of organizations use it to evaluate their own ROI investment in automation. We've made that a lot easier this year through Index Pro. So I would check that out. And I would say thank you so much.
Thank you.
Thank you both.
Happy
birthdays to everyone.
Yes.
We're having martinis in the booth at 4 again.
Oh my God, again?
Yes. 4 to 6.
We have Abe Sutton from CMI coming on our show. Maybe we'll bring him over.
Thank you, Erin. Thank you. Thanks, Sam, in the background.
We got like a Sam. Here, come on camera and say hello to everybody.
Sam, you gotta just really
Sam
quickly,
is like,
just
our
hello.
favorite PR person.
hello.
Sam.
Hello. Hi.
Yeah.
Here.
Oh, right. Hello.
All right.
All right. First time on the talk show.
Wow.
Yeah,
All right.
excited to be
Great.
here. Thanks for having me.
We got Daniel from Welllink.
Yeah.
We don't know what he's going to say. Introduce yourself to our loyal fans.
I'm Daniel Lettenberger-Klein, Welllink Health Alliance. Welllink is a national healthcare association. Recently, changed from a regional hospital association, so massive rebrand, and brought it for the entire continuum of care now. Instead of hospitals and healthcare, we're focused on all of allied health, so everything non-hospital, educational and philanthropic partners, as well as associate members like marketing support, healthcare law firms, accounting firms, so all of industry together. But then also want to educate nonprofit philanthropic organizations as well as research institutions to make sure they're all together in the same room so that change happens faster.
That's a lot.
Yeah.
So you were originally, this is most likely misinformation that Melissa may have never corrected on me, but what Welllink used to be the Center for Health Affairs.
Yep.
And that used to, and was represented a large part of Ohio.
It was really Northeast Ohio. So it was
Okay.
a regional hospital. It's the oldest regional hospital association in the country.
Wow.
First. Started in 1914, launched the first GPO in 1916. We were responsible for launching organized insurance.
Wow.
So Blue Cross Blue Shield of Northern Ohio, which turned into Med Mutual, started in our building, as well as the National Healthcare Accounting Standards.
Wow.
Yeah, so there's some pretty cool history of innovation in our space.
Yeah, God bless Ohio.
Yeah.
So I had heard this change, but what drove that change to working with allied health instead of hospitals?
Well, it's still hospitals and healthcare.
So all you expanded.
I mean, ultimately, we know integrated care is the way of the future, that healthcare systems are very often disjointed. And neighborhood care is also, and in-home care is going to be a way that we move forward. But the change was really led by the hospital systems and healthcare systems having such a difficult time transitioning to the next phase of sustainability, right? So there's a massive threat to the sustainability of healthcare systems from a funding perspective, just across the board. And so for us, we knew we had to flip the script. So traditional healthcare associations across the country are usually based.
Hang on a second, I think something might be wrong. Is everything okay? Uh-oh.
It's because it's sucking out of your laptop. Yeah. Is it dead right now?
Oh boy.
Seriously?
Wow. Nice time.
Yeah. Hold on a second,
Oh,
sir.
you're good.
Okay.
Cool.
Great. Fantastic. Guys, would it be the Health Tech Talk Show? We're gonna have to buy Kat one of those massive power banks, like one of the really just intense ones.
That's the mic.
Oh boy. The best part is that they always they make you pay for power at every booth or whatever as well. So yeah, whenever you do
This is the
whenever you are sponsoring a conference or have a booth, part of the charge is power, which is incredible.
Yeah. They have no outlets over here either.
No, that would be too easy.
Yeah.
That feels okay.
Yep. All right, now we're doing it this way.
All
That's
righty.
creative.
Yep.
Well,
Yep.
it is what it is.
Yep. This is what's happening.
Hey.
Hi. Now we're gonna have to scooch. This is not gonna work quite as it is. Oh, calm down, everyone. Slow down. Slow down.
You got it.
Hi.
It's not working.
There we go.
Not perfect.
Yeah. Well, that's good. All right. All right. We're doing it. We're doing it.
Are the mics working or not?
The mics do work.
Hi.
I think so. Yeah, they work. Okay. Well, anyway, here we are. We're back.
Very good.
We're back.
Fantastic.
So you want me to jump right back into the dues model thing?
Absolutely.
From that part.
100%.
All right, so
Yeah.
we're
Don't worry.
kind of
Don't make it
inverting
good.
the way traditional healthcare associations have worked. So they're typically built on net patient revenue as a dues model on the front end or a cost algorithm on the back end, which for a major healthcare system, really any major healthcare system, could be a 6, potentially even 7-figure dues model. And these healthcare systems don't have that margin. They can't do that on a national advocacy play. And we have such massive issues with margin that it's been incredibly challenging. And so we wanted to have low cost of entry so that we could focus on creating opportunities with advocacy, opportunities with networking, with events, but then bring also solutions to them, different tech solutions. So our most expensive membership model right now is for if a single hospital, not part of a healthcare system, does a 1-year membership instead of a 2 or 3, the most expensive membership is $2,500 a year.
Oh, wow.
And it goes all the way down to $150 a year for an individual or a student or somebody who's retired that's not tied to a healthcare system. And so we wanted to make sure that we were no longer the reason the healthcare system was unstable financially. We want to give them a reason to show up in the room, to be in the room, and then at the same time provide these, interesting, incredible solutions like a Jory AI, the review cycle tool that we work very closely with, and a promotional offering to the members so that they do better. And then by partnering with Jory, we actually are able to support ourselves on the back end through their use of the technology. And so when the healthcare systems does better, we're able to do better. And so it works that way. So it's not cost prohibitive for the organizations.
Okay. So how did the multi-state expansion happen?
That would be Brian Lane, our CEO.
We hung out with him.
Yeah.
We hung out with him.
Yeah.
He's a different human. Brian had been at AHA years ago and had seen the evolution of AHA and the solutions there, and has been a part of Time and HIMSS and VIVE, and has really seen the evolution of associations in the last several decades. And so he has so many relationships built from over the years of doing that when he moved into a position with Welllink, with Center for Health Affairs, Greater Cleveland Hospital Council before that, many iterations, he knew that to create the next phase, we had to move into what he calls One Limitless Link, which is integrating our GPO, which is the largest non-acute GPO in the country, and one of the largest GPOs in the country, across 33,000 facilities utilizing it today, affecting billions of dollars in spend. And then the association, the advocacy piece from a federal level GR perspective. He knew that the way that we could get this critical mass, this influence and volume when it comes to creating one unified voice in healthcare, it needed to be in partnership. And so through his relationship with Les Pitton, who had been the president and CEO of the Healthcare Council, he started brokering that deal many months ago. And associations like healthcare systems are brittle. Right? We've seen that. And as these dues models fall apart because they haven't made the adjustment and evolution, and so many of them are so top heavy, we're in a position where everybody's coming to Welllink saying, how do we partner with Welllink? Whether it's an association that wants to partner with us or merge, or a GPO in the same situation. So he had the foresight to start building those relationships, and that's how this Mid-Atlantic expansion happened for us.
Got it.
Very cool. I can definitely agree with that, right? I think the dues model for associations is famously really, really difficult over time, and being able to prove out the value behind those numbers is really challenging as well. Yeah. And when you think about okay, is this sticky enough that if my budget is cut, I'm going to stick with these guys? That's a whole, that's a whole process. Yeah. Are you familiar with that one?
I am familiar with what happens when things get tight.
Yeah. Well, for us, the goal now is, in my mind, to be the stabilizing force in healthcare. If we do our jobs well, every healthcare system that's working with us is better off today and tomorrow. And so that's really how we impact the community, like what we did with this SDOH Innovation Hub in partnership with AWS. Our goal is to make sure, and our mission is to make sure that we make communities healthier. And so this is how we do it.
Yeah. Interesting.
Love it.
Yeah. That's awesome. You mentioned advocacy GR as another big component. One of the reasons you did the mega merge or mega expansion. What are your key advocacy points?
So right now it's really being built out, and we want the membership to drive it. And so we have an RFP out. We got a response from 6 firms, which was incredibly exciting, federal level firms. And we're reviewing those right now and hope to announce at our annual meeting, May 14th, called Connect NEO, who our advocacy partner will be. Because we're also in a unique position when you do an association for the entire provider life cycle, that you can't advocate for something that is.
Sorry, really quick. Melissa, turn around. She just walked that way.
Who's she looking for?
Miriam.
Oh Lord. Anyway,
sorry, this is a really chaotic.
This is
we don't want to
I
create an
just saw both
advocacy.
of them like going in different directions. Yeah.
Oh.
But no, but so I
We don't, yeah, I want to hear
We
more
don't
about
want to
this.
create a misalignment for advocacy across whether it's a FQHC or a pharmacy or a lab or a hospital system or a physician practice. Like
Yeah.
their advocacy initiatives are different. So we want to make sure we create one unified voice that gives collective strength to healthcare, but doesn't hurt a segment. And that's a very nuanced approach that we're going to have to take to it. And it
very
takes the right
challenging.
partner.
That's
Yeah.
very challenging.
Yeah.
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 No, it'll be interesting. I'm looking forward to seeing what you guys go out with, what you're starting to sort of advocate on, because I am also familiar with that fine line to walk from an advocacy and GR perspective as an association. Like, what does that mean?
Yeah, and our goal is to help create voice and reach and then collective strength. Like what Brian will say is one unified voice in healthcare is ultimately we want to bring strength onto the Hill to argue for the pieces of healthcare that need to happen to create sustainability. Because right now it's every budget cycle that every hospital is descending upon the Hill to say we will not make it if you don't make these changes.
Right.
This is no way for a healthcare system to look for ways to get into a position of sustainability. It's where you get markups. It's where you get, in my opinion, you get predatory practices ultimately too, when you have to think budget cycle
100%.
to budget cycle. It's executives thinking about their pay in that cycle. It's not thinking about how 5 years from now we create well-being for a community. And when the focus on a community is impacted by the leadership thinking about their own pocket, it's never going to be for the best end case.
Yeah.
So it's challenging.
Yeah, you know, I just did moderated a panel on public health innovation, and so similar kind of vibe. Like in general, like healthcare is able to innovate a little bit better because some things stay the same, right? And in the past year, at least, like a lot has not stayed the same, right? And people are freaking out, and so it is kind of a start-stop survival mode, and that's what public health has been in forever because they never have reimbursement. Part of their math, right? It's always massive grants when things are bad,
And then they get
and then
cut.
clawbacks, and then massive grants, and then so you know, no one wants to go in there and do anything. So similar situation, right? You can't plan.
Exactly. And how do you create a business plan when you don't know what 2 years from now is like? And I was the CEO of a behavioral health facility for the last 7 years.
Oh, right on.
And have worked in executive leadership in behavioral health care across nonprofit, for-profit, PE-backed, privately owned for the last 15 years. And in those settings, like especially in the nonprofit space, when it's primarily a Medicaid dependent population, they're largely in need of housing. When you're dependent on that revenue cycle to provide care, every dollar matters, right? And so then it comes into the philanthropic community to support from a grant perspective. But then as soon as you get like what we had, Ohio was working backwards a little bit on funding for behavioral health services, and then it overly burdens the philanthropic community because they're not prepared for that. They don't have the cash flow analysis for 2 years from now when the administration changes and they're going to do a 10% cut in service. So it's
How can you predict that? Like, how can you even possibly begin to predict
Uncool.
Exactly.
Yeah, wild. Why did you leave this? What I can only assume is an amazing cushy job,
It was cool.
running a behavioral health
It was cool.
organization.
And it was actually the oldest nonprofit treatment center in Ohio.
Wow.
It's called Stella Maris, opened in 1948, and was the first sober house in the U.S.
Wow.
Incredible history tied to the
first in Ohio, huh?
So
First.
really
Very cool.
rich history right on the flats, like the longshoremen, the Union Wharf.
Wow.
I got to a point, Brian had been my mentor for the last 6 years because we were recruited to Cleveland at the same time by the same company. And so we had been connected since the beginning of our time in Cleveland. And I knew I heard your birthday's coming up. That's very exciting. My birthday's next week.
Nice.
Pisces.
And so I am turning 40, and I knew that
Don't worry, we've already done that. It's fine.
I knew that if I didn't learn something, I'm a marriage and family therapist by licensure also.
Wow.
And so I knew that if I keep hitting the mic, sorry. I knew that if I
Apologies. That's apologies to
sorry.
1 to 1
I'm very
million
sorry.
fans.
I
Probably 20.
knew I wanted to learn something new. I felt I had some mastery, and knowing budget components that are coming up, I felt like it was, people don't believe this, it was irresponsible to carry my salary at that point, and I knew our COO was ready. And so I said, hey, and Brian had said this years ago, when Stella's in the position and they're stable enough, let's do something together.
Yeah.
And so the position we built the position I'm in now. And the organization was ready. The COO, Christine Robinson, was ready to step up. And it was an opportunity for us to eliminate the COO role, for her to take my role as a new CEO, reset that salary range, and put Stella in a position to be stronger tomorrow. And so I felt like I could also affect Stella in a different way, not being in the four walls, because I could convene people differently. Yeah. And so I still feel very loyal to Stella, and like I want to take care of Stella for as long as I can. But I wanted to learn something new also, and build a skill set outside of behavioral health.
Very cool. Nice.
Very cool.
Mm-hmm.
Any final words for our, again, million loyal fans?
Yeah.
And, for ViVE?
Please come learn about Welllink, the Health Alliance, the GPO. Like, we would love
Did you invite us to your conference?
Yeah, please do. Please do. We would love to have
Is it in
everybody
Cleveland?
be a member. It is. And Cleveland's the best.
I like Cleveland. Okay.
I'm from Chicago, and Cleveland is, and I lived in Atlanta. I've lived all over it. Cleveland is my favorite place I've ever lived.
Okay.
Yeah. It's
Love
incredible.
Nice.
Love it.
Thank
Okay.
you guys for having me
Great.
on.
Thank you.
Thank you
We
so much for
appreciate
coming.
meeting
Really
you.
nice.
And
Awesome.
yeah, we've been
All right.
hanging out with you.
Hand off
Thank
your
you.
little thing to Miriam here. Our
There we
final guest
Final.
of the hour.
Miriam, we need you to show our loyal fans your outfit.
Yes.
Hold on.
But you gotta.
Clip that on her first. Hold on. There we go. All right.
Where do I
Get
look?
in frame here. Yep.
Hello, loyal fans.
Cheap
Hi,
drugs.
Hi.
OMG.
How are
What
you
are you
doing?
doing?
Well, just getting all these texts.
Oh my God.
Getting all these texts.
Hi.
Well, hello.
Okay.
Love your shirt.
Thank you so
Okay.
much. It's the
Yeah.
end of the show. It's the
Look at-
best show.
Look at the vibe.
Cheap drugs.
Cheap drugs. We
Yeah.
help people get them.
Right.
Yes.
RxUtility.
Yes.
So, loyal fans, you may have seen Miriam often on our show. She's our special correspondent on all things PBM, pharmacy, and other things,
Yes.
depending on the day.
Yes.
And she's back.
Yes.
Yeah.
So happy to be here. Thank you guys for fitting me in
Yeah.
today.
What?
Here in LA,
Mm.
the sun is shining.
It
It
is.
is.
I will share a quick story. So we got in yesterday and we had, I had deodorant in my, bag.
Sure.
But I didn't know that there was actually no more deodorant in it. When you screw it in the
Oh,
thing.
yeah.
That was the
Like,
worst.
So I had to go to CVS. So I looked up CVS. I'm like, Lauren, let's go. We had a few hours before our first meeting in the evening. And so the sun was out. So it was CVS. Our hotel's not even 2 blocks from this place.
Sure.
It's not like
Sure.
we're like, okay, CVS, we see it. Now, in my own defense, it turns out it's a CVS in a Target in a mall.
Oh, boy.
But what happened was we never found any of this good stuff, this ViVE stuff with the fancy buildings and the signs. I just took us on this tour through what was every rape and murder alley that you could possibly go through in the back of buildings.
Oh, no.
And the highlight of our trip was the homeless people that were burning their own clothes, which seemed odd. It's not cold. So the guy setting his shirt on fire was a little interesting. But then I just stopped trying to navigate, even with my own map or eyes, and I made Lauren do it. I said, okay, you're in charge of whatever we do.
Teamwork.
I can't do it,
Yeah.
obviously.
For
Even
people
with
who
the
are
phone.
for people who are not here, ViVE is at the Los Angeles Convention Center, which is in downtown. It is a really weird place to have a conference because
Yes.
it is really rough out there. There are people in all states of unhousedness. It's just truly showing you the crisis of homelessness. The people in the throes of addiction. It is always a jarring to see tons of money spent on a conference like this, and people who are like really struggling out on the street. You're like,
Yeah.
all right, you're doing something very wrong here.
Yeah, I was being silly, obviously.
It's very sad though.
But
You're like,
you make a great
whoa.
point. Well, and the other thing is that all of these buildings around where we are, that live place, LA Live,
Crypto.com arena.
all these enormous buildings with all
Yes.
these huge,
Huge,
mega
huge,
stars,
yeah,
and then
yeah,
the people
yeah.
that are. So we
Not great.
I don't think that's right either.
It's not great.
It's
It's not great. It's not great. It's always very confusing. You're like, what's
I've not
happening
been here before. This is my first time at this convention
Right
center.
on. Well, I hear they're not coming back.
They're
So
not
this
coming
is-
back.
yeah.
Yeah.
I've
yeah.
been to LA before, but I usually, whenever I'm on this coast, I'm usually like Thousand Oaks, because there used to be some
Yeah.
offices down there. It's kind of a little ways down.
Yeah.
But yeah,
So you
Yeah,
went,
it's just a little odd.
did you find the CVS?
Yes, you did. And I'm sorry. Yes, I found the CVS and we got the deodorant. And it is like to your point about like this neighborhood or this part of the city, everything in there was locked up. You go to the pharmacy and like,
Oh, that welcome to California.
it's all locked up.
It's everywhere.
So I'm like, oh no, don't tell me in addition to getting all this that I can't even.
You can
But
get your own stuff.
fortunately
Yeah.
for me, I use Dove. Just FYI,
Yeah.
a little shout out for Dove. But for some reason, mine was the only one that wasn't locked up. I was like, this must be not that great of a brand because everything else is
No
locked
one
up.
wants it.
I got my
Oh,
brand,
yeah.
so I got it. And I got out of there, and we had a nice evening. Ran into you guys, which was
Yeah.
great.
Yeah, that was awesome.
It was a nice surprise.
Yeah.
Exactly.
Yeah.
How's it been today for you guys?
Well,
Top to bottom busy, right?
It's always an adventure in the Health Tech Talk Show. We had multiple technical difficulties, even with our
Always
editing and
do.
stuff.
Can't help it. Always do.
It's just part of the show.
Always do. Always do.
Part of the show.
Well, I mean, I think people didn't show. A lot of people maybe didn't show up to the conference because of the weather in the Northeast.
Yes,
Right.
that's
So
true.
it was a
Some of my
little
friends
empty. It
were
was a little
stuck.
empty. It was a little empty.
That's
Yeah,
a little
that's what I would say.
lighter.
It felt empty last year, though. It might just be our
Yeah.
perspective, which is over here in
Overcrowded.
another world.
Right.
So Miriam, so what are you doing, ViVE? What are you trying to do here other than advertise?
Yes, I'm advertising. But I wanted to be here today, and Lauren is here with me to talk about what we launched today, which is our newest addition to our prescription affordability platform, and it's called the Best Cash Price Catalog. So
Well,
we really do, yes.
Which we
Highly
appreciate.
descriptive.
Yeah,
Highly
Health Tech
descriptive.
Talk Show. Yep.
Exactly. So we believe in cheap drugs, but what we really believe in is consumer price transparency around medication.
Yeah.
And so, the thing that people might have top of consciousness for this year, or pricing, or paying cash for drugs this year and pricing, was what happened last year with the GLP drugs when the pharma manufacturers started selling direct to consumers.
Yeah.
So that had never happened before, really, in the history of anything. And so that's really a cash price, right?
Yeah.
And then there was a website launched by the government that had a bunch of cash prices.
Yeah.
And so you are seeing more and more people pay cash. It's about 15% of all prescriptions filled are paid by cash. But if you ask me, what's the cheapest cash price? A consumer really wouldn't know that there are at least 5 major cash discount cards that they can look up a price for. So people are pretty familiar with GoodRx, but there's competition for that. There's a lot of ins and outs of these prices. So we thought it'd be great. Bring every cash price point for every drug. So about 20,000 drugs in rotation right now. There are about 70,000 pharmacies. There are about 4 prices per drug.
Yeah.
So when you do that math, you get into trillions of price points really quickly. And the cash prices are real time, meaning they change throughout the day. They're dynamic. They change throughout the day. Like by the time I got to the pharmacy from my house,
Really?
the price was different.
I did
one
not
time.
know that.
Yeah, it's
crazy.
really weird and it's very odd. So there's no easy way for a consumer to even see the best cash price.
Well, for
It's
sure.
just impossible.
Yeah.
So we thought if we aggregate all of the cash prices and make it available in a simple API, so it's a catalog of cash prices, then those things can get surfaced by all the tech that's here and all the tech that's not here. And if we believe in consumerism, affordability, price transparency, medication adherence, if we believe in those things, then consumers should be informed of what the drugs cost before they get to the pharmacy counter and have an opportunity to just choose. And if they want to choose the best price, the lowest price, they may want to choose what we refer to as the closest price. Because they may be like, I just really like Publix. I just want to go there because I need, some fruit or whatever.
Right.
So they just might want that price. But if you never see the spread, and for my eye drops, the spread on cash price was from $15 to $57. And that's a big spread.
That's a big spread.
So we wanted to enforce. So now we have really every price that a consumer might pay on every drug at every pharmacy. And so we think of it as democratizing pricing. And so then anybody here can consume the data and expose the data. And we have one more element to it, which was we put this, I hate using words that sound like marketing words like decisioning, but I can't think of their words. So like a decisioning layer. So should I use my insurance benefit or should I pay cash?
Right, right,
You know,
right, right,
and
right.
providing a little bit of guidance, like you know, tier 1 generics at $10 per are cheaper if you pay $2 with cash.
Yeah. Wow.
So making a little bit of information available so they can choose.
And there's some number where it starts making sense for you to pay some amount so it goes against your deductible. I'm just waiting until cash prices that we pay go towards our deductible.
I agree.
You know, like because
You're right.
I hear you, and there was a situation where I paid cash for something that's actually very expensive, and I made the judgment. I said, you know, I'm probably not going to get to $6,000 this year unless a terrible calamity happens.
Yeah.
And I don't know if I'm going to be on this biologic for a long time. It also was eye drops, stupid, cyclosporine basis.
Interesting.
And I was like, let me just see if I get to that. Like, I'm going to take the risk right now and go for that cash price. But there's maybe something in there to help me make that decision.
Yeah, I think that's right. So to do that, we need access. This is where we get into a little bit of what we talked about on the PBM reform stuff. There's a positive step forward in that reform regarding patients paying on net price instead of list price. We talked about that example. But you're right. So where you are in your benefit, okay, where you are in your deductible, what the exact price point is for your plan for that tier today. Right? All of that data is available in this transaction called the real-time pharmacy check, this nerdy transaction in CPDP. But guess who we don't let see?
CPDP, I was just exactly. Them.
Guess who we don't let see what the price is?
The patient.
The consumer.
Consumer.
Exactly. So the Karen Alliance, I think it's been 10 years, so it's not like they've been trying for long to get us to put the price in front of the consumer. You know, so it's so outrageous to think that I went to the doctor. First of all, I paid my insurance premium. I went to the doctor and I paid the doctor. The doctor gave me a prescription. They know what the prescription costs, but I don't know what the prescription costs. And no one will tell me and acts like I don't have a right to know. So before you can even get to what you talked about, the analysis of what would be best in my case, I don't even know my choices.
How will you know?
Yeah.
I don't even know my choices. Yeah, exactly.
Do you think like the Trump RX and all this stuff, do you think it's going to make it easier or more confusing for consumers?
I think two things. I'm of two minds. I think it's a positive step forward whenever you're putting information out there. That's price information around price transparency. And it's confusing because it's just another set of prices. And in that case in particular, most of those prices are more expensive than Mark Cuban. And the times when they're cheaper are the times that they're specialty niche products, IVF, and there may be one other, love you. There may be one other.
You got a situational awareness, Melissa. There's all kinds of stuff happening behind you this whole time.
There's a lot going on.
You gotta keep your head on a swivel.
Yeah, the best suit ever. But so it's both. So that's another. So we pull in those government prices too. Right. And so we just want all the prices. I want the lowest price to win. So we're not steering at all. Like we're not saying, oh, here or there.
Yeah.
But if you aggregate all the information, then you have just a very light analytic or a light filtering and have the consumer be able to interact with that price point or the provider or the care manager or the navigation company, the case manager, adherence, helping that person on the missed refill. Well, why did you miss refill? Well, it costs too much. I'm not paying $600 for spaces, you know. So then you begin
That'd be
to
cheap. Try like $1,200.
Yeah, spaces for a while. It's really unbelievably.
I mean, it's generic now, but even the generic is super expensive.
So I do think, Pat, I think it's good, but it is deceptive in that someone might think because it comes from the government, it's the rock bottom, but it's not necessarily true. But you've got Mark Cuban doing such great things. You have PBM reform, but what's most important to us and to me at RxUtility is those reform policy things you guys deal with so much in the work that you do. They're really business to business arrangements. And it might be lowering the cost to the employer, maybe, or lowering the cost of the provider, maybe. But But no one ever talks about, well, how does that go down to the consumer?
Yeah.
Does it show up maybe to the consumer by the time they have played their formulary?
Well, that was a lot of the problems with PBMs, right? Is that there are discounts that are being negotiated. They do not go to the end consumer, the person who's actually taking the drug.
Right,
Just to be
exactly.
totally clear, the discounts are business to business, dealings, right? And I think also, depending on your provider, depending on the EHR, depending on the network, and depending on all kinds of things, they may be pushing you towards something like One Medical, now owned by Amazon. They push you towards Amazon Pharmacy, which does have a lot of really cheap prices for generics. It's not always the cheapest price,
It's not always the cheapest price.
and so you
That's
just kind of that's what it is. So people still have to push to get access to the information about the lowest cost.
They do. So we're talking. That's what I'm talking about. That democratization is just. You don't want to overwhelm. You don't want to say like there's 1,200 prices. So there's a little bit of decisioning in it where you say, well, where's your zip? And what's your plan? Just a couple things, narrow it down. But you're right about those B2B sort of inside deals. Like some people have deals with a company like, let's say, GoodRx, just to make it on the air, that they really are pushing that price.
Yeah.
It's not about consumer choice.
Yeah,
right.
Totally.
So we're trying to figure out how this utility model can make it easy. So let's pull all the data together, curate it, make sure it's correct, make it easy to access in an API. And then we have this sexy MCP server now, this all the rage, where somebody else can consume that decisioning intelligence. So in other words, they don't have to write that code. Right. They want to subscribe to the data, but also subscribe to the sort of sorting and filtering. It makes it easier for people to understand. So, that's what we're hoping. I hope to never build another app or software.
Miriam's a tech bro.
In the day.
Miriam is a tech bro.
Yeah.
It's true. Yeah.
Yeah,
also
I've
awesome.
always been a techie. So.
Well, two more questions, Miriam. One is that I think we asked this when you came on the show as special correspondent, which is sometimes good.
Yes.
Say PBM reform happens, consumers can actually get the best price.
You need to look at what's on the screen with your something.
It's LinkedIn. There's something.
Okay.
It doesn't matter. We're good.
We're good.
We're good. Yeah, we're good.
All right.
Who makes less money if consumers actually have choice?
It's a great question.
I feel like it's mostly the middlemen, but not exclusively.
I think it's not exclusively the middlemen,
but certainly them.
Yes. So one of the anybody that works on spread pricing, which they do, is potentially impacted by this. The one that is the hardest to talk about is actually the one that most people probably don't know about generally, which is those employers that are hooked on the rebate dollars.
Yeah, you talked about that.
To your point earlier, that well, I had to pay more than if I'm. So your employer, let's put everybody in the good guy category.
Yeah,
employers are trying to provide a health benefit to all their employees in a way they can afford, right? So they try to buy a plan and they do benefit design.
So making a prediction about what they're going to have to spend,
right, exactly,
what it's going to look like, what kind of drugs, how much, what are in the super high expensive category, what are in the lower, they're making
the risk stratification of their employee base, all that stuff. This is why almost no insurance covers GLPs because 40% of their population would qualify under the obesity diagnosis. And they before all this race to the bottom of pricing started, but look at what happened in this flip side. When you say consumerism and transparency, those drugs went from $1,200 a pop to $150 a pop in less than a year. And that all happened because of consumer, demand. Consumers are going to get what they need in America or want in America, not even need.
Of Cat's best attempts.
but that, it just shows it. It just shows that it'll work. You know what I mean? So and it can move the margin. The thing with the
it'll work, but then it's not going to be the same thing for cancer drugs necessarily.
No, that's right.
Right.
So that is. We could go down the road of PD. Why do we spend so many research dollars on limp dicks? Sorry, but
you can say whatever you want on this show.
Well, because
demand, consumer demand.
Because we know why.
But there are a lot of them,
for sure. Absolutely.
I'm exiting the talk show. What's happening?
But I'll tell you what. The
I'm not turning it off yet.
the new interest in women's health and the fact that it kind of wasn't interesting for decades is another example of sort of
Yeah, now we're gonna like,
unrecognized
excuse me, I
demands.
would like to get my hormonal treatment that I need.
But now we're coming,
Yeah.
it's coming through, and then people are realizing, oh, it actually is a demand.
Yeah.
So we'll create solutions for the marketplace. So we don't want to try to, we're not in the business of saving money for the health plans or the providers. And we won't lower the utility, and consumer pricing will not lower the cost for an employer, but it won't hurt them either.
Yeah.
It's simply saying in the cost sharing game, if your employee has to share cost, wouldn't you want your own employee to pay as little as possible as they could in sharing costs? Which is why if you're going to use insurance and there's a coupon, use the coupon. But if you choose to not use your insurance and to pay cash, then
here's why that might be worth it to you, and here is the lowest price we can find you.
that you can find.
Yeah.
So I don't think people are harmed. But I do think the spread pricing is already going away anyway because of the reform trends. And what you'll see is those businesses will recover from that lost revenue by coming up with new administrative fees.
For sure.
They're just going to come up with another way of making money. I'm not crying for them. They'll be fine.
They will be fine.
Yeah.
They'll make money and lose money all at the same time, but it'll still go up and to the
It'll
right.
still go up and to the right.
To the right.
Exactly. And
All right.
somehow they'll claim, no, we didn't make enough.
We have final words.
Last words for our loyal fans.
Oh gosh, guys, come see me about some cheap drugs. Thanks for having me.
All right.
We'll be back.
Bye.
Have like
See you guys at 4
It's unclear.
Pacific.
All right. I'm